My name is Dr. Felicia Sussman, and it is my absolute pleasure to invite you into the next in our series of live webinars brought to you from Weill Cornell Medicine and the DIGEST program, which stands for Dedicated Integrated Gastroesophageal Treatment. And this is a program that is dedicated to patients who have conditions that involve the esophagus, as well as other problems that may involve the stomach and conditions of what we call the foregut. Tonight, we have a wonderful panel of physicians that have joined to speak with us about a very common condition that is seen in divisions such as gastroenterology and otolaryngology, and that is difficulty swallowing. This is a condition that is seen and experienced by many patients, and what we hope tonight to do is to give you an in-depth look at why it could happen to a patient, what we do to actually evaluate it, and the different treatments that are involved in the care and management of patients. It's my pleasure to introduce the panel tonight. The moderator for this evening is Dr. Aditya Ashok, who is a specialist in motility disorders at Weill Cornell. Then we have Dr. Anais Rameau, who is an otolaryngologist and specializes in the evaluation of patients who have swallowing disorders and a multitude of other conditions that are related to otolaryngology. Dr. David Carlock, who is a nationally recognized interventional endoscopist and performs many expert and intricate procedures on patients who have swallowing disorders, as well as Dr. Philip Katz, who is an esophagologist and will be rounding out the conversation this evening, helping us understand all the different mechanisms and ways that we might evaluate patients with esophageal disorders. So I'm so excited to hear what they have to say tonight, and I'm sure all of you that are listening will learn so much about this very common condition.
Perfect. Thank you so much for that introduction, Dr. Schnell. So before we get started, just have to put this disclaimer out there that what we're talking about in today's webinar does not constitute individual medical advice. And some of the speakers may have financial interests in various products in these spaces. Okay, so the other thing that I think it's always helpful to sort of contextualize this, Dr. William Moser, one of the greats, the founding fathers of internal medicine, really talked about how studying patients without diseases and studying diseases without patients are both fraught things. So we're going to try and ground today's discussion in really both of those things, patient experience as well as sort of the science behind what people have been experiencing. So in terms of what we're going to be talking about today, we'll be talking a little bit about how we think about difficulty swallowing as physicians, how common it is, what some of the causes are, the different things that we have in our arsenal to really evaluate this, and then talk finally about some of the different treatment options that we have, which depend on sort of what it is that's causing it. So we'll start first with how do we think about difficulty swallowing. So just to ground this again in a patient experience to make it real, our patient here is a 55-year-old man. He's coming in, has had 20 years of chronic heartburn, happening at least 4 times a day, per week, that he has treated with over-the-counter acid suppression medication. Previous smoker, his weight has been stable for years, and he's just noticed that they just don't go down the way that they used to, and that it's more difficult for him to enjoy his steak dinners. So now we'll have Dr. Katz and Dr. Rameau really weigh in on sort of how we think about difficulty swallowing and how that might differ from not being able to swallow. So Dr. Rameau and Dr. Katz, you could take it away.
Sure. So good evening. Thank you so much for joining the webinar. So this question is actually one that we've studied with Dr. Katz. we've looked at really the difference between difficulty swallowing and objective findings of swallowing dysfunction on exam. So difficulty swallowing is really the experience of the patient of having difficulty swallowing saliva, liquids, solid foods, and the experience can be varied. Some patients will feel like things are getting caught. Some patients will be coughing when they're drinking liquids. Some patients experience choking. And again, that's a little bit in contrast with the findings on exam. So what you experience as a patient can be a little bit different from what we see on our exam. And so we always try to understand the relationship between the two. And a lot of the time we try to find a way to improve the swallowing function and get you back to feeling comfortable with swallowing. And so I think that's what you're trying to get to here with the question.
I totally agree. To amplify, I want to understand if you as a patient feel that the food does not move as you would like it to. We would look to see if you had a problem initiating the swallow in an area of specialization for Dr. Ramu. Problem with it going down the esophagus or in the chest, which would be predominantly an esophageal problem. And then to differentiate, as my colleague said, is it with solids alone, thinking about a structural problem? Is it liquids alone or both? And we think about other problems in that case. And then if you have actual pain with swallowing, we think about a differential diagnosis that's slightly different.
And just sort of tying all of this together as well, Dr. Katz and Dr. Ramon, can you weigh in a little bit about difficulty swallowing versus not being able to swallow, which is, sort of like what's a outpatient issue and what's really like an emergency?
Or so not being able to swallow is very concerning. So sometimes we see that in some of our patients who've been treated with radiation to the head and neck, and they might have some difficulty with passing the food into the top part of their esophagus. And that's concerning because you might not be able to get hydration and nutrition. And the hydration is particularly an emergency. So in that case, you would need to be seen right away and go to the emergency room.
Patients who have what we would call an impaction with food usually might tell you or tell us that they cannot swallow at all. They can't swallow saliva. Nothing will go down. Difficulty swallowing, a little different. Things go, things move, maybe slowly, not always regular. Things may feel like they go down the wrong pipe, as the cartoon would potentially indicate, forward into the trachea or the lungs. Not being able to swallow means it just won't move. Or it might start to move and come back.
You both for highlighting that really important but subtle distinction. So returning a little back to our patient, we see him in clinic, and when he's thinking about it further, he realizes that he's actually had difficulty swallowing for more than just a couple weeks or even months. The food he feels like has been getting stuck in his throat after he is able to initiate the swallow, and he has to drink some water to flush it down. A few times he's actually had choking episodes, one of which required his wife to perform the Heimlich maneuver. So I'm wondering here, Dr. Carlock, if you could weigh in a little bit about how this changes or influences how you're conceptualizing the case, and talk a little bit about the Heimlich maneuver in particular, because I feel like everyone has familiarity with that phrase, but really to understand what it's going to intervene on.
Oh, thanks. The two histories that somebody will give you in clinic or wherever you are seeing your patients, of the type that you just heard about, the one where it's difficult to swallow and the other where you can't swallow at all. These two may go together because often a patient who presents to us with what Dr. Katz called a food impaction, which is an emergency situation, patients come to the emergency room because they cannot swallow anything. But you talk to them once you've treated them, we'll get to that, and you get a history that something was going on for weeks, months, years. Like the patient that we started with, there have been symptoms for a long, long time. Just not ones that would take you to the physician or take you to the emergency room. So it's very important to get that history from a patient because it tends to tell you that this is probably a benign condition since it's been there for 10 years. Or if it just happened in a few weeks and progressively got worse quickly, and maybe there are other symptoms like weight loss, makes you think of a much worse diagnosis. So the history of how the patient tells you that their problem started and continued and then ended up being the way it is when they're seeing you, that's a very helpful thing for us before we start doing any sorts of tests. So that just a quick word about the Heimlich maneuver. Remember, this is a little different. This is because the airway is obstructed. And why is that? Because if you look at the picture that you see on the screen, the airway is right in front of the esophagus, literally, and anything that obstructs the esophagus can also obstruct the airway. And that becomes absolute emergency, has to be dealt with immediately. A person who's got this problem may pass out, and then you have to start thinking about resuscitating them. But before they do so, if they're still conscious and they're telling you that something's stuck and then they can't breathe, then you need to unobstruct the airway with usually a piece of food. And the Heimlich maneuver in an adult is done the way that I think everybody should know. Not quite sure it's exactly like the way it's shown in the picture because you usually stand behind the person and allow a sudden, forceful, positive pressure from below the diaphragm to push the food out and expel it and open up the airway. It may not treat anything like the esophageal problem that we're going to talk about more of, but it will release the obstructing piece of food in the airway. The patient can breathe. So that's very much an emergency situation. So that's the sort of background to how we see people who come to us with various stages of difficulty with swallowing, and then, of course, the emergency situation where complete obstruction of the esophagus causes complete inability to swallow.
And I love, Dr. Carlock, that you were talking about the weight component of this, right? Because as we recall with this gentleman, right, his weight was stable for years. And you had alluded to this and really described some of the things that make you more concerning or make us more concerned, one of them being weight loss. What are some of the other things, that you think about as really concerning features when someone comes in with these issues?
We've mentioned a couple already. Any pain on swallowing, which has a specific name for us, but that's something that alerts us if it's acute or if it's been there for some time. That's not a good feature. Weight loss we just mentioned. Drooling, the inability to maintain a complete swallowing. I just want to go back 1 minute right at the beginning. Remember that swallowing is something you don't usually think about. Right? It's a natural action. You don't think about, oh, I'm going to swallow now. You do it. So anything that interferes with that is unusual. And you start to think, well, why is this happening? And that's sort of encompasses the whole idea of difficulty with swallowing, depending how bad it is. So weight loss, certainly. There are certain tests that we do that look for anemia that indicates that maybe the patient's been bleeding from something chronically. And anything that it concerns the patient because it got worse. Somebody who has progression of symptoms from something that they can tolerate to something that they cannot tolerate in some way or other, usually because the food won't go down adequately. That's a very concerning feature. And again, doesn't necessarily imply a bad diagnosis, but it implies that we need to do something about it.
Thank you so much for that, Dr.
Well,
Go ahead, Dr. Katz.
Well, occasionally focus on whether the difficulty in getting food down is intermittent, irregular, or whether it's continuous. That might give us a clue to the diagnosis. Always being present with both solids and liquids gives us a little more push one way than something that is pure solids. And I think it's indirectly been emphasized already that where the food gets stuck, or at least where the patient feels it, may not be exactly where the problem lies, because of the way the esophagus tends to refer pain. So we don't focus quite on that as much. But Dr. Carlock makes an excellent point that if you as a patient actually have to think about getting food down, that's a very unusual situation in our lives, and should raise the thought that you should see somebody sooner than later.
Thank you for that. I think that really highlights how we think about it and sort of make it concrete in individual patient. So, Dr. Katz, then, if you could expand upon this and talk generally about how common this is and sort of the difference between every now and then and sort of what a chronic issue is here.
So this is a key point. Almost all of us have had an occasional time where something might feel like it went down the wrong pipe, or didn't go down quite so easily. We were rushing, we didn't chew, we took a big gulp, and never happens again. Don't think about it. That's probably more common than even this 2% of the population. But overall, when something happens in 2% of the population, it's actually common. And this is something that is what we call chronic, meaning it happens again and again and again. Even something that happens once a month over time should be of concern. But that's what I think the concept here in terms of common. Gastroesophageal reflux disease, what people call GERD, frequent heartburn and regurgitation of food, actually are associated with difficulty swallowing. Dr. Carlock alluded to weight loss, which would raise concern, including rapid onset of a cancer. Motility is a descriptive term for movement, motion. People with solid and liquid dysphagia, or solid and liquids that don't go down like they feel like they ought to, makes one think about a contraction disorder. Names of disease, achalasia or esophageal spasm. And then a large variety of neurological diseases, including Parkinson's disease, can cause or be associated with difficulty swallowing, where the primary problem is not in the esophagus, but is more generalized, and the esophagus is affected.
I'd love to try to bring into the conversation some of the many questions that are coming up from the attendees. And, some of these are very specific, but I just would love to have, a brief comment about one that is addressed to Dr. Rameau that specifically has to do with Botox injections that are some patients get, that they have treatment for cervical dystonia. So this is a very specific question, but basically just bringing up the concept of some patients that might have food getting stuck. We were talking now about neurological diseases and things of that nature. If you could just give a brief commentary on how that there might be other more invasive or involved things, or what your team might do at times to try to tease things out like this, that would be wonderful.
Sure. So I am not able to see the question in the Q&A, but sometimes when you get Botox for cervical dystonia, you can get fairly large doses of Botox, and Botox itself can have some secondary effects on your overall neurological status, and that includes with having difficulty swallowing and impacting the muscles of the throat or the pharynx. And so we see that occasionally. The good news is that the effects are self-limited. So usually within 2 to 3 months, we'll see full resolution of those symptoms. It's uncommon, but occasionally we'll see that in our clinic. In terms of management of swallowing dysfunction, Botox may be used sometimes in the upper sphincter of the esophagus or the food pipe. And sometimes we do that in order to relax that muscle when that muscle is obstructive. Sometimes it can be too thick. And we often combine that with a dilation of the upper sphincter of the esophagus. And the doses of Botox that we use are fairly small, so we don't expect to see the secondary effect of having swallowing dysfunction from that Botox injection.
That's perfect. That completely addressed the question that was at hand, which was related to some side effects that can happen from that. And I really appreciate you addressing, excuse me, some of the different therapeutics that you can do at the very, very entry to where the esophagus is. So thank you for contributing that.
Sure.
Dr. Rameau and Dr. Schnell. So next, we're going to be talking about how we evaluate it, right? How we evaluate this difficulty swallowing, because we spent a fair amount of time talking about how we conceptualize it, what are some of the causes. So we're going to go through some of the diagnostic tests that we have available. This is a huge list, of very specific tests. We're going to go through each of them, sort of describe what they are, and really ground it back in our patient's experience. But briefly, Dr. Rameau and Dr. Carlock, I was wondering if you could go through some of these and give us sort of a brief rundown. Maybe we could start with you, Dr. Carlock, with the first 4 or so, and then Dr. Rameau end with you for the last 2.
Sure. So, patients get referred to the appropriate specialty by somebody. And Dr. Katz mentioned something that I think a lot of people don't realize, is that the esophagus is not very cooperative in telling us where the problem is. The exception might be what you will hear from Dr. Rameau in a moment, that pharyngeal, in other words, throat symptoms that feel like they're in the neck, probably that's where the problem mostly is, not always true. Whereas anything else below the neck, all the way down to the upper abdomen, the problem in the esophagus can be anywhere in that tract. And it doesn't really tell us exactly where it is. So in other words, you have to think of it in those terms and design a test, depending on the urgency, to elucidate where the problem is so you can treat it. So these are some of the things that are available to us, not necessarily ones that we do on everybody, and certainly not ones that we do immediately when we're trying to figure out what the problem is. But the first 2 are certainly the most commonly used as a first step. Upper GI endoscopy using a flexible endoscope under sedation to look at the entire esophagus and stomach. And of course, we do look at the lower part of the throat before it becomes the esophagus to try and detect any physical changes that explain the patient's symptoms. And there are a whole variety of those, which we'll probably come back to in a moment. The barium esophagram has been around a very long time. It's getting a patient to swallow barium, which is very dense on an X-ray, and following it down from the swallow, from the initial swallow in the back of the throat, all the way down to the stomach on an X-ray machine, and recording images or video at the same time. Again, that tells us when something is physically or even non-physically, like the motility issues that Dr. Katz mentioned, are present, because we can see the outline of the esophagus and the bolus of barium, which is sort of trying to copy a bolus of food, tell us where it gets held up, or there's a different shape of the esophagus, something that has caused that patient to feel the difficulties in swallowing. So those 2 are the most commonly used initial tests, and sometimes both, because they give us slightly different information. And then if that either that doesn't explain the symptoms completely, or it appears that there's no physical blockage to the passage of food, but it looks like perhaps the esophagus just isn't working normally, it's not moving things along the way it should, Then we go to a different test that specifically look at the motility or the motion of the esophagus, and that's what number 3 is, looking at the pressure waves, which we can now do very accurately, and you're going to see some of that in a moment. And then probably the newest one is number 4. It's another way of looking at how the esophagus behaves, and this can be done in somebody who's conscious or somebody who's undergoing the first one, the upper endoscopy, can be done while the patient's asleep. And that'll give us further information, particularly about how the sphincters, the 2 circular muscles at the top and bottom of the esophagus, are behaving. And it's often the ones at the bottom that clearly are most commonly involved in providing the symptom of difficulty with swallowing. So those are just some, although they are the main ones that we have at our disposal to look at patients who have this complaint and hopefully provide us a diagnosis.
So we
Amazing.
just, yeah,
Go ahead,
sorry.
Dr.
So we just talked about how to evaluate the esophagus, and I often tell patients that there are 3 phases to swallowing. There's the mouth part, the throat, and then the food pipe or the esophagus. And so the last 2 tests are really focusing more on the first 2 phases, the mouth and the throat. Particularly the video fluoroscopic swallow study focuses on the mouth and the throat. It's a little bit like a barium esophagram in that you're going to be swallowing barium of different textures, but the focus is the mouth and the throat. And that allows us to see how the food is transitioning from the mouth to the throat and what happens also as the food is transitioning to the esophagus. So here we're really looking at the relationship between the swallow mechanism and also the airway. We want to look at how safe the swallow is, and we want to look at how efficient it is. And then the fiber optic endoscopic evaluation of swallowing, the short word is FEES, is done in the clinic. It's done with a little camera through the nose, and then we give you food of, again, different texture, and we're looking at how you're swallowing this different texture, paying attention to the safety and to the efficiency of swallowing. So is anything going down the wrong pipe? And is there a lot of food left over after you swallow in the throat?
I think we'll show some imaging which will make it much more obvious to people. One thing that right before Dr. Katz talks about the esophagram, a question that came through is a lot of what we're talking about is about difficulty swallowing. There's been several comments from the audience about feeling like they have a lot of the saliva that is still sitting, especially in the top of the throat. And I would love someone to address whether or not that also could be a symptom that is related to difficulty swallowing. Not just that they have difficulty with food, but that they feel like the phlegm is constantly collecting in their throat. Can that also be a symptom related to what we're talking about today?
Yeah, so I'm happy to talk about this because this is a common symptom in our patients in the ear, nose, and throat. So, we produce a lot of saliva and mucus. So it's been estimated that somewhere between 1 and 1.5 liters of saliva and mucus is produced every day. And normally we just swallow it and we don't think about it. And so when our ability to swallow the saliva is decreased, then it's really bothersome. Then you can feel that saliva accumulating and you're much more aware of it. So oftentimes when you're having difficulty with that mucus sensation, it could be that you have swallowing dysfunction in the throat. And then there are other reasons from a more lower GI perspective that my colleagues here can comment on.
Maybe we could start going through, and then it'll be obvious in some of these studies where that might, bring clarity. But thank you so much. I think it's sometimes, people think it's only food or liquids, but even saliva could be an indication that there's a swallowing disorder as well.
Amazing. Thank you. So returning back to our patient then, he underwent a barium esophagram. And just to sort of contextualize this for people very briefly before we have Dr. Katz weigh in, barium is just something that looks dark on X-ray. So that's what you're going to see going down. So if Dr. Katz, if you don't mind going through this real barium esophagograph for us.
So this is a short video. You see the barium very well outlined, moving down the esophagus relatively efficiently with a single what's called stripping wave, and then a small amount of retention at the bottom, which is not totally an indication of something abnormal, but if it sits there for too long and doesn't empty or regurgitates back, it could indicate the potential obstruction at the bottom, usually in this picture related to incomplete opening. I will comment that you get a look at bones. You can see if there's something pushing on the esophagus. You can look at the great vessel that can push in on the esophagus just under the clavicle, which are those two bones across the top. And you see the heart in the background. We don't really focus on that, but the barium study does give you the opportunity to look for things that might be external to the esophagus, plugging and causing a blockage.
Dr. Katz, what is the ruler on that trying to show what that's outside the patient? If you could just explain to the attendees what that is.
That's actually a very sophisticated picture that can look at the height of the barium column when the patient is sitting upright. And it can help determine how high the column is. Otherwise, I'm not totally sure what it's measuring.
Amazing. And as you were saying, Dr. Katz, this is essentially, we see a normal stripping wave. This is essentially a normal study, right? So another one of the tests that our patient ended up having was esophageal manometry. And I'm hoping you could sort of shed some light on what exactly that is, how we do it, how this image makes it look worse and more painful than it actually is.
Well, this is actually a highly sophisticated and very important way to evaluate esophageal function, potentially upper esophageal sphincter function, and in Dr. Ramu's case, where you are expert, you can actually look at pharyngeal to esophageal manometry. So you can really understand how the esophagus functions. As Dr. Carlock indicated, this would be a test that would be done further down the road when we couldn't figure out what was going on with an endoscopy, a biopsy, a barium study. This is a test that most people are told they shouldn't like and is scary, but someone who knows how to perform this with some very good local anesthesia can slide a tube down into the esophagus, across all the sphincters, just into the stomach, and with a series of liquid swallows, sometimes a solid bolus given in various sequences, gives us an incredibly good look at movement and esophageal function. The next picture will actually show us that.
Perfect.
So
There's a lot of detail, obviously, here, Dr. Katz, but if you could walk us through this.
This is a pictorial view of what you actually see. You see the sphincter open at the top. You see the bolus move down efficiently. The purple at the bottom where the lower esophageal sphincter opens. So you can look at opening at the top if you can freeze that. If you can't, that's okay. That's the opening of the upper sphincter. Movement of the bolus down the esophagus is pointed out here by Dr. Rashok. Opening of the lower esophageal sphincter, which should occur almost simultaneously as the upper. And the dark purple is indicative of what we call bolus movement, which is a way of looking at how things move independent of pressure. So the swallows are pressure and sequence. The purple is bolus movement, and actually, this is a pretty normal looking manometry, but it gives you a flavor of what we can actually discern with this technology. So if you need one of these and somebody tells you that you should be afraid, call us before that so that we can do our best to reassure you how important this information is.
Perfect. Thank you for making what is extremely complicated testing straightforward, Dr. Katz.
I'd love to bring
So,
one question,
sorry, go ahead.
up just because like we were talking a lot about anatomy and people are commenting on that sometimes things get caught in their esophagus or throat and then they can actually bring things up through their nose. So if someone could just comment, so that people understand the anatomy, is there a connection, because we spoke about the esophagus and the trachea, but we didn't really talk about the nose in particular. What's the relationship between like the nasal passage and the esophagus and stuff like that? Maybe
I'm
Dr.
happy.
Cornell.
Yeah, I'm happy to take this one. So the nose is connected to the pharynx or the throat, and it's a passageway for air, obviously. But the throat, the pharynx, is also connecting to both the swallow pipe and the air pipe. So the esophagus and the trachea. So if you're bringing things up either from your esophagus, and sometimes that happens when we're vomiting, for instance. Things can actually come through the mouth, but also through the nose, because the nose, again, is connected to the throat.
Thank you. Perfect. Yeah. Sometimes
I might actually,
weird.
I think Dr. Carlock could actually make a comment or two here about Zenker's diverticulum of the upper esophagus that sometimes can catch food and have it regurgitate out of the mouth or up into the nose. Dr. Carlock, since you have a way of taking care of these, as does Dr. Ramu, it might be worth a comment.
Yes, they're the territory where Dr. Rameau stops and we start is the same place, the upper sphincter of the esophagus. And you heard just now about difficulties in handling saliva and sometimes food also, and then regurgitating it or spitting it out, sometimes frequently, but particularly at night or first thing in the morning. These are all features of conditions that can affect the upper sphincter. And one of them, described by Dr. Zenker a long time ago, is where part of the back of the throat is caused to make a sort of pouch or balloon. And in fact, it's called Zenker's pouch or Zenker's diverticulum, which is a fancy Latin word for the same thing. And it can collect, as it grows over time, sometimes years. The saliva and food can get trapped in it and be regurgitated or just stay there, sometimes for a very long period of time. And there are lots of dangers of this condition, one of which is that whatever food is retained can regurgitate into the airway, particularly during sleep, and cause pneumonia and coughing during the night. So there are lots of symptoms that are associated with this, often that get overlooked. And patients eventually come to us when the symptoms are severe, and you find out that symptoms have actually been there for years, and then we treat them. And there are many ways to treat them, but they're endoscopic now. They tend not to be surgical anymore. And both Dr. Rameau and ourselves have slightly different ways of doing the same thing, which is to deal with the cause, which is a high pressure in that upper sphincter of the upper esophagus. So, this is yet another condition that causes difficulty with swallowing. It's not that unusual, but it gets overlooked very often because the symptoms are pretty mild at the beginning.
And I can't think of a better segue talking about the nose and where GI starts and ENT sort of ends is go Dr. Rameau walking us through what a modified barium swallow actually is.
Yeah, so this was actually the test that we previously called the video fluoroscopic swallow study. Sometimes it's also called a modified barium swallow, so a lot of complicated words here. But basically what this means is that we're looking at the swallowing in the mouth and in the throat, such as what you're seeing on the video here. So this is an X-ray video. So there is some degree of radiation, but it's not a lot of radiation. And you're holding some barium, which is an inert metal, and it appears black on the X-ray. And we're able to see how that barium is traveling from the mouth into the throat. In this case, it's a fairly normal study, and we're seeing that there is a very smooth passage from the mouth to the throat into the esophagus, and nothing is going down the wrong pipe into the trachea, which is basically the lighter gray color. And I don't know if you can see my mouse. Can you see my mouse? No. Okay, so a lighter, okay, perfect, gray color at the front of the neck. So that's the air pipe, and we don't want things to go down into the air pipe.
Dr. Mo, if things, there have been a lot of questions on coughing, and we haven't really touched so much on that. But with this test that we're looking at, the modified barium swallow, is that a test that might be done in patients who have coughing?
Yeah, absolutely. So if you're coughing, especially while you're eating, while you're swallowing, then it could be that some of the food could be getting close to your vocal cords or to your trachea, your windpipe, and that can lead to a cough. And actually, we want you to cough as a response to that because that's the normal reflex. And so on this swallow test, these type of video fluoroscopic studies, we could see sometimes the barium getting into the airway and seeing a cough as a reaction to that. And it's not normal to have food go down the wrong pipe, but at the same time, we want you to cough if that happens. If you don't cough, then that's quite problematic because that means that your body is not able to respond to that airway invasion, and that can lead to complications such as pneumonia.
Thank you for that. And that kind of leads also well into the next sort of topic, which is you had mentioned this earlier, what we sort of colloquially call fees. But I was hoping you could also walk us through this, Dr. Rameau, and sort of the preparation here and what it feels like and the test itself.
So this test is not done in radiology. It's done in the ear, nose, and throat or speech language pathology clinic. And basically, it involves passing a small camera through the nose into the back of the throat. And then with that camera in place, we can look at what happens during the swallow in the throat. And we don't actually see exactly what happens during the swallow because in the normal swallow, the throat is contracting. And so there's a little bit of a whiteout, and we don't see exactly what happens during the swallow, but we can see what happens before and after. And what we don't want to see is food that's going into the vocal cords, if you want to point out to the vocal cords, and past the vocal cords. And we also don't want to see a lot of food left over after you swallow. And we also prefer not to see food getting into the throat before you swallow, because that would also be abnormal. And so we have a very set protocol with all the colors you're seeing. We're using natural food dyes to add colors to liquids of different density or texture, and also to purees, puddings, and crackers, so that we can actually see where the food is going as it travels into the throat.
And Ace, how long does one of these tests take to do?
It takes between 5 and 10 minutes. We have a standardized protocol that's validated and national standard. So it takes a little bit longer than maybe at other offices, but we're being extremely thorough and taking a lot of different measures.
Thanks.
Thank you for that tour de force, really, Dr. Rameau. So let's bring it back a little bit to our patient.
You do anesthetize the nose for that, correct?
Yes, so we spray the nose, and it's very well tolerated. Most patients don't even think about the camera because they enjoy the different foods we're handing them. So it's very well tolerated.
into a competition of which is better tolerated, Dr. Katz, the esophageal manometry or the fees.
Oh, feast wins hands down.
Yeah.
Okay, so bringing it back to our patient then. So we underwent a diagnostic upper endoscopy, that test that Dr. Carlock had beautifully walked us through. We're able to put a scope down after a patient is fully sedated and look at their esophagus. And we found erosive esophagitis. Um, and biopsies were done, came back benign. But I'm hoping, Dr. Carlock, you could really walk us through this image here, what you see, orient as, etc.
Cool. So a lot to talk about in this one picture, but I'll summarize. So remember, the reason that we're doing this endoscopy is because the patient complained of difficulty with swallowing, has been treated with medication and improved a little, but not completely. And we'll come to that again in a moment, what we do in that situation. But what you're seeing here is the typical endoscopic image from our modern endoscopes, which produce an electronic image, which has been sampled here for you. This is the place where the esophagus joins the stomach. And if you can point out, Addie, the change in color, maybe on the right where it's a little bit more normal, the change in color, the pale lining is the esophagus, and then as it becomes stomach, it changes to a slightly reddish color. And that's the transition between those two linings that we like to see in everybody. And that's the place which is hardest hit by reflux of acid. So that's where we categorize the degree of inflammation, which we call esophagitis. And often this is where other things occur that will cause difficulty with swallowing, as in this and is in this patient. But what you also see on the left side of the opening is it's a little bit more red. There's even maybe some blood there. It's very irritated. And this is the esophagitis I just mentioned. It's almost certainly caused by reflux of acid contents into a place that's not prepared to deal with it. That's the esophagus. And so it causes injury to the lining, and this is the appearance of 1 degree of esophagitis. It can be less than this, it can be more than this. And the consequences, if it's not treated, is that it can cause ulceration, loss of the lining of the esophagus and this junction between the two, and even scarring, which eventually might cause what we call a stricture or stenosis. And that is a very common sequel to this chronic heartburn. Remember, this patient's had heartburn for a long, long time, probably not treated adequately, and he's overweight. I think his BMI was 30. That's another factor in reflux disease. So we have a diagnosis, unless there's anything else that we missed on the endoscopy higher up. But if this is the only finding, this is certainly an adequate explanation for his symptoms. And the reason that he's not completely better from the swallowing aspect, although he may be much better from the heartburn aspect, is that there's now some scarring that's occurred exactly where you see it here. And that's fixed. That's not going to change with medical therapy. And this is something that we have to intervene on to relieve that symptom. And we'll talk about that a little more in a moment.
And as Dr. Carlock had beautifully said, right, this is something that we saw endoscopically, we biopsied, made sure it wasn't anything bad, that essentially it was not cancer, and treated him with some acid suppression. But, as Dr. Carlock was saying, wasn't enough to get rid of all this scar tissue.
This would also be a good time, Dr. Ashok, before Dr. Carlock goes through this next slide, to remind people that there are differences in the dosing strength of many of the drugs that they can use over the counter. This person had been on pantoprazole at a 20 milligram dose. That's not a prescription level dose. That's an over-the-counter agent, which would have little likelihood of healing. And in a patient like this, one of the new class of agents that are called potassium competitive acid blockers, which are more powerful at controlling acid than the current proton pump inhibitors like omeprazole or lansoprazole or drugs like it, would be something to use in somebody with this severe disease. But as Dr. Carlock said, it's unlikely to completely resolve the obstruction because of the chronicity and the fibrosis.
Dr. Katz, while you were mentioning the new class of medication, there have been several questions about the PCAB class of medication. Could you just describe the difference in time between being on a proton pump inhibitor and a PCAB? How long, if someone were to have reflux symptoms or even swallowing issues related to reflux, what is the difference in time? Like, how quickly could PCABs actually start to show their effect?
So proton pump inhibitors are drugs that require multiple dosing to reach what's called a steady state, usually 5 to 7 days, by the nature of how they work. This new class is much more rapid. The way it inhibits the acid production is so quick that sometimes it will reach its peak effect in 1 to 2 days. So in the setting of need to relieve symptoms, which is unusual to have to do it that quickly, the potassium competitive acid blockers, or PCABs, are much faster. In addition, they disappear quicker. So if you don't need the drug, it will disappear faster than proton pump inhibitors. And eventually might be able to be used in an on-demand way where the current proton pump inhibitors are not very effective.
These are the medications are now available to patients. They're able to get them in like regular pharmacies.
It's a prescription product. It's approved by the FDA. It's a single tablet once a day. There are a few plans that pay for them very simply and easily. Therefore, they're available in any pharmacy. At this point in time, there are some special arrangements that can be made for patients who need them and are not covered on their plan to allow people to get this with some element of a copay.
Thank you for that. Dr. Carlock, maybe you could walk us through. Our patient comes back after not having improved um, on just a prescription strength acid suppression, and this is what we sort of encounter on our repeat endoscopy.
Okay, so what you're seeing here is exactly the same area that you saw in the other picture just now, now after treatment. Remember, the endoscopes we use are anything between 9 and almost 10 millimeters in diameter, so they're fairly small. And they will often pass through an area that's narrow, but if they can't, because that area has become so narrow that our endoscopes will not go through, then of course food won't go through either. And that's why the patient still has symptoms. So the simplest method for dealing with that is to stretch it. And we have a number of ways to do that, but this is the most popular, using a balloon which is passed down through the endoscope channel in its collapsed form, and then it's inflated with, in this case, water. So it's called a hydrostatic balloon. We used to use air, but air is compressible, so it's not a very good way to stretch something if you really want a predictable result. So this is a balloon which will expand to a specific diameter according to how much pressure you put into it at the top end outside the endoscope. And this is what it looks like during the time that it's being inflated. The patient, of course, is asleep, so it doesn't feel any of this. After it's been stretched to a certain diameter that's required for the situation, the balloon is then deflated, and that's what you see in the right-hand picture. It's the same balloon. And now you see that the opening has become much wider. It's usually bleeds a little bit, as you see here, which is not a concern. It's predictable because the tissue is not quite normal. That balloon is then withdrawn, and a larger size balloon can be passed if necessary. And interestingly, what you see in this picture, now that you can look through the junction between the esophagus and the stomach, is what's called a hiatal hernia. There's a part of the stomach that's come up above the diaphragm and is in the chest. And that's part of the mechanism of reflux disease in most patients. And now we can see it exactly here in this particular patient. But the important thing is that that opening has now been dilated or stretched. The symptom of difficulty with swallowing or dysphagia will now improve. Will it improve completely to normal? Time will tell, but this procedure can be repeated if necessary, because as I mentioned just now, scar tissue, once it's formed, tends to stay there, which means that this narrowing can come back again on a subsequent occasion.
Amazing. Thank you for that wonderful description. So just to recap, right? So we have our 55-year-old gentleman. He came in, chronic reflux, found to have a benign peptic stricture, that is a narrowing from acid exposure, who was treated with prescription strength acid suppression, and then who subsequently required a dilation, as Dr. Carlock went through. Dr. Carlock and Dr. Katz, I'm wondering if you could just briefly talk about the spectrum of treatments that we have available. We talked about, two of them, but there are more.
Well, this is a perfect example of synergy between medication and endoscopic treatment. The proton pump inhibitor or the potassium competitive acid blocker got the patient so far. Dr. Carlock indicated that with either graded or repeated dilations, you can get to a point in which the esophagus or the stricture is open enough. This patient would require now going forward either long-term acid control to keep that open, perhaps a periodic dilatation, assuming things would not be refractory, and then ultimately might be a candidate to repair that hiatal hernia and prevent reflux via a surgical mechanism, of which there are multiple types, including endoscopic interventions, which I will defer to my interventional colleague to perhaps expand upon.
One question, just while you're saying that. So the hiatal hernia, Dr. Carlock, that you saw, there have been a lot of questions in the chat about hiatal hernias and the relationship between what's going on with this patient. And so did the hiatal hernia cause what we saw was really the question at, could this cause all the symptoms? Did this lead to the stricture? Is that what you thought was going on?
Good question. People have some interesting ideas about hernias, not quite understanding what they are. Hernia just means as a part of an organ that's in a place where it shouldn't be, usually because it's passed through an opening somewhere, like hernias in the groin. The same principle. Some part of you has gone through an opening that may be naturally there or not naturally there, but has formed to a place where it shouldn't be. And a hiatal hernia is a typical example of this. There are different types. This one is called an axial or sliding hernia, so it comes and goes. But what it implies is that the hiatus, which is the opening in the diaphragm through which the esophagus usually passes, has become much larger than normal and has allowed part of the stomach to ride up into the chest. And that's what we saw in that picture. And that's a hiatal hernia. So it's part of the mechanism of reflux. What comes first? Does the reflux come first or the hernia? And, we have debates about this ourselves, but it's very common. It may not always be the same size. I have patients say, well, last time it was 2 centimeters. Now you're telling me it's not there, because it's flexible, it's variable. It's not always in the same place. The patient's position is different. And of course, they're under anesthesia when we do an endoscopy. So that's not a natural state. So it is part of the mechanism of reflux and very commonly present. So do we treat the hernia? In general, we treat the reflux first because that's so much easier, and you've heard how we do that. And in this particular patient, because there's a mild stricture, long-term acid suppression is really essential. Losing weight would also help. Remember, this patient's BMI was 30, so weight loss, he's already stopped smoking, so that's also a good thing. And there are some dietary modifications that might help the symptoms. But it won't change the way this is all happening because of the physical presence of a hiatal hernia and reflux. So what happens with long-term acid suppression is that it does reduce the chance of that stricture coming back, although it may still do so. It also does reduce the risk of other things happening. We haven't talked about this condition of Barrett's esophagus yet and cancer that can come from it. We should just touch on that before we finish. But there, of course, are ways to treat the hernia specifically. And then up till fairly recently, they have been surgical, as Dr. Katz mentioned, many types of surgery with different people's names on it that try and remove the hernia by pulling the stomach back down into the abdomen and keeping it there by doing something to the hiatus and to the stomach itself. And that's really been very successful over the years. However, most patients don't want surgery for this. Some will have it and some will not. And I tend to reserve specific patient categories, just refer to my surgical colleagues, usually young patients who don't want to take pills for the rest of their lives, people who are not completely controlled with the drugs that we have, or for some reason cannot take them. So there are patients that will fall into the category where surgery does seem a good option. And now we have methods that we can use endoscopically to recreate the valve that's now not functioning very well and allowing reflux to occur. So there are a number of ways we can do that. But this is actually quite a small percentage of all the patients who have reflux because acid suppression medication has been so successful. However, the stricture part does require intervention in a patient just like this, and dilations may still be required over a period of time, but maybe just infrequently, like once a year. And if that's something you have to discuss with the patient to see if they're willing to do that.
Thank you for that, Dr. Kroc. We actually do have separate webinars on Barrett's esophagus, its diagnosis and treatment. So I would encourage everyone to check that out. And with that, we have reached the end of our talk. I first want to thank our amazing panelists, Dr. Carlock, Dr. Rameau, Dr. Katz. And I would be remiss if I didn't thank our fearless leader and head of our digest group who sort of spearheaded all this, Dr. Schnell Sussman. So I hope everyone will be able to join us for our next webinar on June 10th. And we're going to be talking about reflux and hernias and more depth than what we were just had the chance to do.
Thank you so much, everyone. Have a good evening. We look forward to seeing you on our next webinars.